Good evening, everyone. So here we are today with an 86-year-old gentleman, and he's a known hypertensive with non-diabetic and non-smoker, and he had a long history of class 2 angina for past 5 years, which progressed slowly to class 3 for past 1 year. He didn't give any history of rest angina. In April this year, he developed some COVID pneumonia, but it was mild. He was not hospitalized. He recovered fully, and he came to us with class 3 symptoms. So when we examined him, he was hemodynamically stable. His ECG showed no significant changes, and echo was normal LV function with low nasal wall motion abnormality. Since he was having exertional angina despite optimized medical treatment, we did his an angio, and we planned for his angiography. Can we have his angio, please?
Can we see the angio? Actually, his creatinine that time was 1.9, so that was a point of a little concern. But in view of his increased symptoms, we decided to do a procedure, and that was taken up about 5 days or week back. So that's the angiogram. If you can run these pictures, can you someone? Yeah. So that was the diagnostic angiogram, and as you see, there is a long segment severe disease in the LAD, and the LAD is calcified. Circumflex system looks okay, and there is a epicardial big collateral to the RCA, and the distal RCA is a big vessel, and it is filling through collateral, suggesting it's occlusion, total occlusion. Onwards, please, if you can just go on forward. Just keep moving, please, now. Yeah. So similar things, we see the collaterals, but the collateral is very tortuous. If you see epicardial across the AV groove, and the LAD lesion is critical. It is almost subtotal type. There is some antegrade flow. Keep moving forward, please. And there is calcium there, and it is a long segment disease. So forward, please. Further on, please. So similar pictures. That's so that's the LAD filling. The filling is slightly slow, and you see some negative contrast boluses, suggesting that this is also getting some collateral from somewhere. So it is nearly subocclusive. The ECG was almost okay. So can we stop it here? And the LV, as I think Rupali said, LV was preserved.
Yes, sir.
So with this, I wonder what you would do if you want to say something. Any opinions, Ziad or?
Sure. Let's open the discussion.
That's the right. So we knew it is occluded. So that's the right injection. That's in LAO and RAO, please. So the right is occluded. There are some bridging collaterals, as you see, and through the bridging collateral, some flow goes antegrade, but then it mixes with the retrograde flow largely from the opposite side. We can stop that, and you can have thoughts on that, what is to be done for this patient.
So a challenging case, good clinical indication of progressive angina over time that's under controlled with medical management, so a good indication. So I think you have a number of challenges in this case. Obviously, the JCTO score here is high. You have an ambiguous cap, a long lesion. Unfortunately, the assessment of your collateral circulation interventional collaterals is limited by your high-grade LAD lesion.
Yes.
And also, unfortunately, a lot of panning in the original angiogram. But I do think that you can tackle this with a hybrid approach. One approach may have been to actually intervene on the LAD at the time of the original angiogram. And what that would do is try to increase some safer collaterals and open up some septal channels, albeit with the caveat that you may have jailed some of those septals. But I do agree that using an epicardial collateral for that right, which is highly tortuous, other than for visualization, that would really be my last resort. Kevin, anything to add on top of that?
No, that's right on. Yeah, I mean, I think, there is a little bit of risk to fixing the LAD first, and some of the collateral can be jailed. But you can usually get through them with a small 1.5 dilation out the stent into the septal. So it doesn't necessarily knock off that option for the future.
Okay.
And a little bit of clarity from dual injection angiography will help just to determine what the strategy could be for either integrated wire escalation or ADR potentially. But I agree with Ziad, and I think the faculty there going through that epicardial would be really last resort.
Actually, that is exactly what was there in my mind. So when he came 7 days back, actually I did his LAD. because the LAD was subtotal, and I thought I should stabilize him with the LAD. You can just keep running the angios. So we did his LAD, and because of the calcium, actually, there was some deficiency in the opening of the balloon, so we did a rota, and with the rota, we could finally do the LAD. And we can just see the last shot, maybe just keep running and go to the last shot. So that's the stent coming up. And then there was a chunk of calcium there, actually, if you see, and that needed a high pressure dilatation. You see that. That's the chunk of calcium, and so finally we managed a reasonable result. Can you see the last angio? Last angio, yeah.
I just wanted to, so this looks like it was done only sort of a week or so ago,
Yes,
correct?
yes, correct. Just a week ago, but
just
with the thought that maybe some septal collaterals could grow, or and the patient would be more stable now. You see, because now I have an opened LAD, so when I'm doing the RCA, I'll have a more stable patient, and that's one of the reasons we did the LAD first, and especially because LAD was part of the culprit, because the flow in the LAD was really subtotal. And that is the situation which is more responsible for the worsening which had happened in the last 6 months to year maximum.
So let me ask some of the panels. Dr. Mustafa, after fixing the LAD, would you, and if the patient has a significant improvement in anginal symptoms, what is the utility of the RCA CTO in that situation? Would it be something that you would do routinely, reassess symptoms?
Especially in this case, considering the patient's age, I think she's like octogenarian. I mean, he's 83 years or so. And if the symptom has significantly improved, probably I may not venture into the RCA. And especially the RCA looks like a CTO. So it's not going to be an easy RCA. But at the same time, if the patient continues to have this angina, probably I may attempt the RCA.
You see, exactly. Now the thing is, I agree that the symptoms would improve with LAD, but and he is not that young a patient that we are looking for longevity for complete revascularization purpose. But the point is that the RCA is equally big. It's rather very big, and this patient had worsening symptoms only in the last 3 to 6 months, or 6 months maybe, but is symptomatic with significant angina for 2 years. So I'm sure if LAD was responsible for the worsening, the RCA is responsible for that class 2 to 3, whatever class 2 angina he was having for 5 years. So I want to give him a much better life, and if I can open the RCA, it may be a good idea. So that's
definitely. There is no doubt about it. Like any coronaries which it is openable, we should open. There is no doubt about it.
Next.
So with that point, I think we decided to do the RCA, and so that's how he is here now. So these are the current, I would just show you the current angiograms so that we ensure that the LAD that we did is fine, because that's one most important thing. So that's the left injection, so LAD looks fine, and there are some collaterals that have come up through the septals. Now you see that?
Very nice.
They have come up through the septals also.
Yeah.
So we have that option in case.
You have some distal collaterals which are actually not jailed by the stent, which are highly favorable. So you've really opened up a lot of options here. So
that is a strategy.
I wanted to ask you.
Because CTOs have to be done with strategies. You see, so that's the strategy we apply.
And
now can you see the right? So that's the now for doing the procedure, I do CTOs in biplane. Now you see, now this is the biplane shot, because for diagnostic procedures we cannot, contralateral, because for diagnostic procedures you can't do contralateral, because otherwise you need one more puncture, which you can only afford during the intervention. So now, so the real picture comes out when you take up for the intervention. So now that we have it, so now what we see here is, previous one please. Previous one. Okay.
One more. Yeah.
So that's the biplane shot that we have just given, and that shows there are bridging collaterals from the RCA which which overflow it antegradally, and then there is an area of slush somewhere in between mid RCA. There might be some disease in the in between segment. So that is the RCA CTO. So we are now going to do it. So
can I just ask a question? Like in this case, at this scenario, you would like to go for a straightaway, a retrograde, or you would try to do an antegrade and then
I would,
what is your
actually, I would actually do antegrade. You see, there are lots of, actually antegrade also, there are several options that we have. We'll try antegrade first, wire escalation. If it doesn't go, actually I do something called 3D wiring. If it is possible, then we'll do that. Else, ADR is also a good option here. ADR is also a good option because the distal vessel is good sized. So let us see what happens, and because the occlusion total length is about 20 millimeters. It is not too long.
It's not too long. Yeah, that's
yes.
right. Yeah.
So I have a feeling that we might succeed antegrade itself. And otherwise, we have both the options for the retrograde. I think we will prefer the septal to the epicardial.
Retrograde.
Okay,
Yeah.
so let's get started. Tell us what's your original approach, what microcatheter and what wire you're going to throw.
So I right now, you see, I have a microcatheter. This is a Terumo, which one?
Fine cross.
Fine cross. This is a fine cross microcatheter that I have. And I just have a Sion wire to take it down, that's it. And now I will actually take the CTO wire. So I'll just
is this your routine to use a non-braided transit catheter for CTO?
Yeah, for antegrade, I always use fine cross. That's what, because the visibility is better. You see, it's radiolucent all the way. So whatever, but you can use any catheter. People use Corsair, but for antegrade, usually I prefer, what do you call
Fine
it?
cross, sir.
Fine cross.
Dr. Waradekar,
And now
how
what I'm
long
going
do
to
you
do is,
wait for visualization of collaterals after stenting of an lateral vessel? Do you think a week, 6
ideally I
weeks,
would
2
wait for at least 6 weeks. And that is the, now I'm taking a XT wire. That is my first wire that I take usually. It finds its way several times, So that's
Kevin, what would your initial wire and microcatheter be?
Turnpike Spiral, Mongo, or Pilot 200 typically.
So that's the XT wire.
Dr. Mustafa, what would your
Yeah, it will be like
and wire be?
Yeah, we'll be taking like this. I mean, with a microcatheter, and Fielder XT is my first choice, and then I might try a
Because
Gaia
I
wire.
have seen Fielder XT cross some very difficult lesions sometimes. So let us see what this does. So
Suresh, what would your approach be?
No, I'm an interventional radiologist. I don't think I'm qualified to answer that question.
Well, we'll ask you about the biplane imaging.
Yeah.
Yes,
How about you, Ziad?
16.
Turnpike spiral, and then I'd probably use a Mongo. If it didn't go really easily, I'd switch to a Gaia.
Yes, please.
Okay, so you've got a fine cross in. You're making some early progress with the Fielder XT. I mean, at this stage, do you think it's worth a retrograde? See where you are?
Yeah, but I don't think it will fill all this all the way up. Let's see.
Biplane.
Come on. Left injection, please. It's not filling all the way there.
Okay, I mean, I think you're doing reasonably well, yep.
Yeah, let's see.
Ziad, I'd be interested in your experience. The Fielder XTA with bridges like this sometimes will find its way through the bridge into dissection plane a little more readily. So that's why I typically take something with a touch more tip ram force push. But I think there's a lot of variation among lots of expert T2 operators. Now I sort of abandoned an XTA as one of the initial wires because it tends to go in places I don't like more often than not in my experience. But I know that others feel
It
differently.
looks okay, sir.
I agree with you, Kevin. Typically, I reserve an XTA for when I actually see a small microchannel visually. So if I can see a channel, I think it'll probably sneak into that channel. But if I can't, and it's actually a occlusion, I like something like you with a little bit more gram weight.
Yeah, it looks okay, sir.
The nice thing about it is it will knuckle pretty readily if it doesn't go into the right spot. So that part of it gives you feedback, at least from the wire tip shape.
Left
That's
injection,
looking
please.
very promising.
Where am I? In the RAO, it is somewhere.
Can you just freeze it?
It looks like you're on top of the vessel in this view. Maybe another.
Just bring it back, sir. I think you have to go a little on the right side.
So tell us what angles you're working in straight RAO and
There's a straight RAO and a straight LAO.
straight LAO. So maybe
They
a
have
little
a
bit of
biplane.
cranial here, if you can afford it, will help. To
I don't know where
No,
I
sir,
am.
that's enough.
I don't know where I am. Left injection, please. I could change the wire maybe.
Yeah, I think that will also. You have to just.
So the
RAO
micro has
plane-
come down.
Yes.
Can we see the left injection once more? No.
so
I
you're in the
think-
sub.
Yeah, looks like that. I think I'll have to change the wire. I'll probably change the wire right now.
So tell us your approach here, because you're setting yourself up kind of nicely for a Stingray anterograde dissection reentry.
I think this.
So-
I'll get a better
Gaia.
wire which has a little
Gaia
more
two.
power. Let me take a Gaia 2, so that I can
The
Gaia 2.
the fine cross microcatheter is probably in a dissection plane already. Will you back it up and try to reattempt more proximally, or are you going to try to re-enter from this point?
So my experience in these, Kev, is that if you're really past the plaque and you're in an actual, a subintimal space where there's relatively little plaque, it's very, very hard to re-enter.
I agree. So I'd probably back it up and start over is what
Yeah.
I'm suggesting. Do you agree with that?
Absolutely. I think pulling this back and trying to find a new channel. And to be honest, this is where parallel wiring can be very helpful.
Yeah, we can do that.
I would be very judicious about how much work we do here, because you're in a beautiful spot right now to bring a Stingray down and try to re-enter. So
I agree.
you should be judicious about not enlarging that sublingual space by spinning lots of wires into it.
Yeah, actually,
Additional to that point, if available at some point, I'd probably jam a guideliner down the artery to try and limit inflow to the sublingual space at the moment we decide we're going to convert to a re-entry approach.
Subintimal.
Dr. Ziad Ali, actually now since he has made, reasonable progress with the microcatheter, so either he has already reached the exit block or he is into subintimal.
Yeah.
Well, I think this is pretty clearly in the subintimal space.
Yeah, this looks like
Okay.
subintimal. Yeah, I know that. I think we'll need to change the strategy now. If this is subintimal, either we do ADR,
No,
either
is
we
it-
do
is-
ADR, either we do AD. I think ADR would be a
ADR
better
would be
option.
Because you can go to the.
I think this is a beautiful ADR case.
Yeah.
There's a couple of reasons. One, you're on top of the artery, so that's very favorable for you. I would try to get onto the flat part of the artery,
Yeah.
and then bring the Stingray, and really try to sort of puncture into this with ADR next before I go retrograde. You have all your options on the table.
Yeah. I think I'll try a ADR first.
It sounds like we're going to move to another live case and come back.
Yeah.
We'll be looking forward to your progress when we get back in a few
Okay.
minutes.
Okay. Give me a trapping balloon.
Yeah. Okay.
A couple thoughts, Ziad, on Stingray-assisted ADR for hematoma management. And what wire do you like to deliver the Stingray down on? I used to use Miracle Bro, but recently I've been doing it quite successfully with a Mongo because it's just simpler and easier because it's often
Yeah.
there in the case.
I learned that from Bill. He just says deliver in the Mongo.
Yeah.
I have to say I haven't been doing that yet. I'm still delivering on a Miracle because I especially with the LP Stingray, I feel like it gets stuck a little bit. And so I just feel like I can push harder and keep my, the position without further creating the subintimal space with my Miracle. So I'm still, to be honest, using the Miracle. So are we moving over to another site? I believe we're going to another live case. Is that right?
Yes, sir. We will move to other live case and we will come back to Goel sir again.
Trap.
Good. Thank you, team. We'll be in touch shortly.
Okay, let's see where we are. Hello, we're back. Dr. Goel?
We actually did a ADR, and to cut the long story short, I could successfully do it. So I'll show you what all happened. Can you just run what? And right now I am in the PDA. You must. So that's where I am. You see that? The wire is in the PDA. So what we did, go ahead please. Can you show the angios please?
Yes, sir.
Yeah, so maybe you can show us in sequence what you did.
Yeah,
what
sure.
your-
Oh, no, dekho, tumhe, you have to go back and then start. You can't sort of just keep going one by one back. You have to jump immediately.
Back.
You have to select from the boxes, go back to an old screen, make the boxes, go back. We left somewhere here, or piche.
No, that's
Start
what
from here. Start from here, let's see.
Next.
Okay.
No, move forward. Okay,
Next.
move forward. So move forward.
Yeah.
So that's where we were, okay? So then at this stage, what I did, I was with a Gaia wire. You see that, and I was subintimal. So what
Yeah.
I did was, I first dilated that tract with a 1.5 balloon, okay? On
Okay.
the same wire. Move forward, please. Move forward. Just
And
hold
so,
on. So, yeah, sorry.
Is that your routine strategy to use a 1.5? Typically,
You see-
we don't do that
You
to
see,
prevent intramural venous failure.
I'll tell you why my strategy is. I am in a subintimal track, right? Now I need effortless travel of the stingray balloon in that track. So people used to do it with crossbars when they were doing electively and all that stuff. But what I have observed, and I have done it myself, I have seen that if you dilate the track with a 1.5 balloon, your stingray balloon moves without resistance. So the purpose is only to let the stingray balloon move without resistance. And in all this deal, I have not played with my distal wire so that the distal dissections remain limited. That is why I did not do parallel wire also, because once you do parallel wire and all that stuff, then you create a lot of subintimal dissections and planes in which you can't see the distal vessel and then you can't succeed. So the wire is still there, so I've done that dilatation with balloons. Go ahead, next. So I think the balloons might be coming on the way. Go ahead. So, and in that deal, now you see, I am seeing from the contralateral side that I must be able to see the artery there well enough where the distal tip of the wire is. Because if I can't see it, then I will not be able to succeed. So the other trick that we do is, then I also did what is called straw with the stingray balloon. Move forward. I think the stingray balloon is still not come.
No, sir.
And in the meanwhile, I changed this wire to Miracle 12. Because Gaia is not a good wire. It will go anywhere and all that. So you have to do this procedure on a Miracle 12. So now, right now, the wire is Miracle 12. The stingray balloon is in place, and it is inflated. And as you see in the LAO view, you need two views. In the LAO view, it is flat, and in the RAO view, it is still narrower. That means it is sort of in profile in RAO, and it is end face, whatever you call it. It's in LAO. So we want the view in which it is flat, so that the artery is on one side and the balloon is on the other side. In fact, in this LAO view, the balloon is so flat that it is overlapping the artery. So you can't make out where it is. But in the RAO, if you see, the artery is on the left of the balloon, if you can appreciate that. The distal artery is on the left of the balloon in RAO view. So what I need to do is to push my wire, the stingray wire, onto the left side in RAO view. So that is what exactly I did. Next. So now the miracle has come out because we need space for the stingray wire will now go in, and we inflate this balloon. There is technique to prepare the balloon which is important. I think had I done that live, I would have told that, or I can tell you after. So now, and I have at this stage, you see, I don't see the distal vessel so well. I did straw here, and with that straw, the distal vessel was better. And now there are two holes. One is in between the two markers, and one is proximal to the first marker. So I am trying to get out onto the left side. So one hole is on the left, the other is on the right. So now you see in biplane, as the wire is being pushed, it is heading towards the left side on the RAO screen. Once I see it heading towards the left side, I know it's going in the right direction. And I will move it forward, but now this is a stingray wire which several times you get in fine, but then you pierce later subintimal because the wire is not as good, as flexible. So this is the maximum it went, and at that stage I pulled this wire back.
So which wire is this we're using?
This is stingray wire, the stingray.
Okay.
And then this is pilot. Now that I have gone, because pilot you have the liberty to play with it, because you see it is not as damaging. So the stingray wire made the hole, made the connect through the proximal hole into the main artery, and the pilot wire followed that track, and beyond now it is fine. So now that's the pilot that has gone in. I cross-checked it, and then it was, we see through a PDA into some branch or something. So then we realigned it, and that is where we are. We then took out the stingray, extending the wire, we took it out, did some balloon dilatations around the thing, and so I have done with 2 millimeter balloon, and now you see my contralateral injection, I can't see the right. Why? Because it's probably flowing antegrade. That's why we don't see it so well, okay? So now what I want is I'll probably do it with a 3-0 balloon, and maybe I can even do an angio with a short injection, no problem, after having done with 3-0, and then put stents. And I think it'll need some long stent, maybe 2 of 38 or 40 or something like that. So that's what I'm going to do. So I wonder if there's time, you can wait with me, but otherwise, this main thing is done. I'm sorry I couldn't show the OCT because, you know, CTO takes time. That's the issue.
Of course. Well, a beautiful description, a step-by-step of how to do a stingray procedure, a difficult CTO in which you used a staged procedure to increase your likelihood of success, stenting the culprit lesion, improving your visibility with retrograde collaterals from the septals, a beautiful example of how to use the hybrid algorithm using an antegrade wire technique, and then upgrading to an antegrade wire escalation successfully. So it was our pleasure to join you, and we thank you for your time.
Thank you.
Thank you.
Thank you.
Yeah, good.
I think that's a fantastic case. Well, you can see I have opened the right.
So nitro
I have put a stent. I think we need some nitro on the distal vessel. Am I visible? And
I think they are disconnected from this, sir. I think.
I see. Okay, well, we can see their angiogram. So nonetheless, well, thanks. I'd like to thank Dr. Mustafa, Dr. Crochet from the Brigham and Women's, and all of our colleagues and all of the audience who joined us today for 2 excellent cases on different spectrums, CTO PCI as well as left main PCI. Hope to see you soon again.
Okay, thank you. Bye-bye.